behalf of the Integrated Health and Wellbeing Council, I welcome all of you to this Breast Cancer Awareness Series, which is an initiative supported by Roche. I'm your host, Behjat, and today we'll be discussing about breast cancer in young women, unique challenges and considerations. And to discuss about this very pertinent issue, I have with me Dr. Harish Kancharla, who's a consultant medico-oncologist and hemato-oncologist at Yashoda hospitals. So without further delay, I will just welcome him to the show and start the discussion. Thanks for being with us, Dr. Harish.
Thank you so much. Thank you so much, Raj, for providing this opportunity. I myself, Dr. Harish Kancharla, working as a cancer specialist and hemato-oncologist at Yashoda Hospital, Somajiguda, Hyderabad. So this topic we are going to discuss today is very pertinent and very important, especially breast cancer being the most common cancer in India in women. And so we always see that the number of cancer cases in the last 2 decades has been increasing, especially breast cancers. And Indian subcontinent has a different scenario compared to the Western countries in terms of stage of diagnosis, the biology of the disease, and we have our own things like supportive care and emotional social support and affordability issues in our continent, basically.
Right, Dr. Harish. That was a very apt introduction that you've given. Coming to breast cancer, like you said, the numbers are increasing. And when we talk about and compare our statistics with Western countries, so here it is happening at a much younger age.
Correct.
And so if we talk about the risk factors, why do you think there is this shift? Why younger women are getting prone to breast cancer? What are the reasons? And if you could enlighten us on them with respect to the risk factors for the disease.
Yeah. So if you see the traditional risk factors described modified or non-modifiable risk factors, most of the non-modified risk factors like age and the hereditary and genetic recurrence. So apart from that, main these modified risk factors like early menarche, late menopause, and the use of contraceptive pills and obesity. These are all and of course the addictions like smoking and some cases alcohol and use of OC or oral contraceptive pills. These are all increasing the risk of the breast cancer, especially shifting the median age towards an younger age group, especially because of the late marriages and first child delay. In some cases where they generally think to have a baby at later stage, the increase in number of menstrual cycles increase the increased proliferation of the breast tissue and increase the risk of cancer. So late marriages and late first childbirth and obesity, inactivity, physical inactivity, addictions, and over usage of old contraceptive pills. This is all the part of the major role. Those there are several other factors need to be uh, considered and which need more further investigation with the trials and observational studies.
Right, Dr. Harish. Coming to the unique challenges that young women face when compared, when we compare them to older counterparts, when they are diagnosed with breast cancer at a young stage, what are the unique challenges that you as a healthcare provider have to, consider before going for any treatment modality?
So, younger population always win, not only in breast cancer, whenever young population getting the cancers, why apart because they are going to be long term survivors, and we always think about the long term side effects and like infertility and cardiac toxicity or any effect on other side of secondary cancers. We have to take in care of, especially infertility. The infertility because it's a major concern because the kind of chemotherapy agents they are exposed, they have some bit of 1 to 3% of infertility in the long term, especially particular regimens like anthracyclines and platinums. So that's the one my primary importance because breast cancer patients, if they're young women who are yet to expect a family, so after completion of treatment, so because most commonly the breast cancers, the survival rates are increasing. They're going to long-term survivors. They can plan their pregnancy later point of the time. So always embryo preservation in a married couple or ovary preservation in a unmarried woman. So we always explain these things to our younger populations so that they will take in.
Right. Dr. Harish, am I audible? I think there is some network issue at Dr. Harish said. Dr. Harish, can you hear us? Yeah. Yeah. Can you hear us?
Yeah, I can.
I'm audible. Yeah. So when we talk about breast cancer in young women, how do it differs in terms of tumor biology, prognosis, and treatment response? How is it different from when we talk about breast cancer, maybe in older women?
Yeah, if you see that cancers are tend to be having an older age group. Most of the cancers can because of the with age the number of mutations increase, the number of sporadic mutations, somatic mutation increase with age. Someone is getting the cancer that young age means that always they do have aggressive biology, and there definitely has to be dealt with in a different approach. Someone having probably having a family history, someone having BRCA positivity, and someone having advanced disease at presentation, someone having aggressive type of breast cancer like TNBC. So younger women tend to have more of triple negative breast cancer, which is aggressive among these three, and they don't to have advanced disease at presentation, and they have high chance of relapse in spite of giving the all the best possible of surgery, radiation, chemo, all combined. And if you see overall as a breast cancer, when you compare to the Western countries, the Indian subcontinent have a different division of the breast cancer presentation in terms of stage of the disease, they and in terms of the type of breast cancer. If you see the Western literature, the stage 1 to cancers they make up to almost 70% of the cases, and if you see our Indian studies, Indian data, the 70% of the dose were in stage 3 and 4. There's a reverse of this thing. Stage 1 2 are very few cases, like up to 10 to 20% in our setup. It is different in our Western setup because it all attributed to the screening programs are in place in those countries. Still, the screening is always an opportunity screening we are doing as of now. Most of the people do not aware that what age they have to get screened for breast cancer and what kind of modalities are available. And a lot of more of education need to be done, especially in villages and of course in even urban setups also. So with this increasing screening availability, with increasing screening awareness, so definitely the survival rates are going to improve and we can detect the cancers at earlier stages. Yeah.
Right. Coming to the long-term survivorship considerations, which are specific to young women. So, after breast cancer treatment, what is the risk of recurrence, and what are the late after effects of treatment? Modalities that can have an impact on the quality of life later.
Yeah. So main concern long-term effect and long-term side effects are depends on what kind of chemotherapy they have received, and of course, most of the young women we do suggest an breast conservative surgery so that they will not have any stigma or cosmetic issues. We do the conserve the breast with addition of neoadjuvant chemotherapy, reducing the tumor size. We address the micrometastasis, and we offer the conservative surgery along with plus or minus lymph node dissection as per their diet test. So in those patients who are being offered radiation therapy based on the risk of cancer type and aggressive nature and advanced nature of the disease, the long-term radiation effects we look for, and any kind of cardiac toxicity secondary to the medication they receive, especially anthracyclines. And long term, 1% of the people who receive anthracyclines may get acute myeloid leukemia treatment related, which is very aggressive and lethal. So we keep them on follow up for almost like 10 to 15 years. To whenever there's a possibility, we do the annual screening of the opposite breast, and to look for the recurrence chances in the opposite breast. It happens around 5% of the cases, and distance recurrence based on their symptoms. And we see for there's a long term side effects like infertility, and with whenever they have symptoms to echo monitoring, and whenever they have any kind of issues, we can simply diagnose these long term side effects like leukemia with simple blood test called peripheral smear. And apart from that, we have to take care of the bone health, because whenever they give chemotherapy to the patients, some may attain like an androgenic menopause kind of picture, because complete ovarian ablation we have to do in some patients to give the hormonal effect. So ovarian ablation and long term usage of these hormonal agents and chemotherapy may have issues with the bone density. So we have to take care of this fracture risk, and we do keep on maintenance supplements like vitamin B12, vitamin D, and calcium supplements. Along with that, we do DEXA scans in those patients who are at risk of osteoporosis, and someone who is having a on risk of osteoporosis. We do suggest administration of bisphosphonates, calcium supplements, sometimes change of regimen, and we explain about the physical activity and the type of precaution they need to take care to avoid the fractures.
Right, Dr. Harish, this is about their physical well-being. But when it comes to psychological and emotional aspect of a breast cancer diagnosis, how do these factors influence treatment decisions and outcomes? And what role do family caregivers, support groups? What is their role? What role do they play? And you, as a as an oncologist, how does it work? Like, is there an interdisciplinary team? How does the the journey go?
Things are changing very rapidly these days. Initially used to be the cancer treatment is focused around surgeon and medical oncologist or radiation oncologist. Those are the three main pillars of the treatment in the in the past decades. But the things have changed so much. From the inception of the treatment, the genetic counselor and psycho oncologist, nutritionist, and other elements of the treatment. Giving treatment is one part of treatment, and explain them about the nature of the disease, the intent of the disease, and to avoid the risk factors in the future, and to analyze about the genetic nature of the disease, if at all, to address the other family members and the patient herself or himself. And we have so much of supporting staff like psycho-oncologist and genetic counselor. We all involve all these guys. We are part of the panel called multidisciplinary team meeting. Whenever the breast cancer patient comes to walk into our OP, so the final management of the patient will be discussed in a tumor board, which includes the surgical, medical, radiation, plus the pathologist and a radiologist, and as well as our supporting staff like psycho-oncologist and genetic counselor as well. So because the BRCA testing is recommended for all breast cancer patients, initially we used to assess this BRCA testing in only those patients who have certain risk factors. There's one or two families already affected, or someone got in a cancer at a younger age group. But these days it's recommended in all patients. So the percentage we get is around 5%, 5 to 10% of all breast cancers, and more common among triple negative breast cancers. So why we do, and whenever the patient comes, especially younger age group, if you discuss about the fertility, we discuss about the genetic nature of the disease in any subcontinent, we have more of a stigma that it may go up to lead up to divorces in some cases, and may not they may not get all the support from their partner, especially for the part of the treatment and the future course of action. So whenever we are breaking the bad news, we have to counsel the both partner and the patient, and as well as the curative nature of the disease with all available treatments. So it's a curable malignancy, and most of the cases they be detected in the early stages, and they can live normal life after the completion of the treatment. And testing for BRCA is just protect their children or siblings, and it opens up more of treatment options like PARP inhibitors. So the kind of counseling is different. We have to just explain in a right way why we are doing this test, pre-test counseling we call it, then only the emotional part and the social stigma will be taken care of. Yeah.
Coming to the, though you touched upon the body image question here, because when young women are going for mastectomy or other surgical interventions for breast cancer, there are concerns about body image, and of course, how is that tackled, and what are, though you touched upon it briefly, but if you could provide us a detailed answer on that.
So yeah, definitely, for any age group, removing entire breast is definitely not cosmetically acceptable, and definitely they will affect their on psychological way also, like based on their body imaging and some taboo that some most of the cases will give the option to the patient, especially young patients. We always offer breast conserving surgery only. Even someone is about 50 or 60 also, we always discuss with about the patient. If the patient is an eligible candidate for conservative surgery, we always go for conservative surgery. But we give them option also. Some patients, they always request for removing the entire breast. So on patient request also, we do perform MRM. After that, we can provide breast processes, as well as we have help of like plastic surgeon who can do the reconstruct surgery, and there are options even after you do the MRM, and will taken care of even after completion of treatment. So definitely the things have changed these days, and most of the patients we are offering BCS, that is breast conservation surgery only. Few patients who request for MRM or who are not a candidate for breast cancer conservative surgery because of small volume of the breast or large size of the tumor and advanced nature of the disease with skin involvement. Those cases we have to go for MRM, then followed by breast processes as well as the reconstruct procedure. They do help to taken care of this social stigma and body image issues.
Right, Dr. Harish, talking about breast cancer or any other cancer for that matter, the earlier it is detected, the better the diagnosis and treatment, the better the treatment outcomes are. And when we talk about specifically about breast cancer, so in India, we see that most of the patients are diagnosed at a later stage. So, what are the guidelines and recommendations for breast cancer screening, especially for the risk for the population that has risk factor, family history? How often should they go for screenings? At what age? What is your take on that?
Yeah. So usual recommendations for average risk patients among all population, like with us recommended as above 40 years of age group till 70 years of age group, we suggest annual screening mammography with the both breast, and this is general recommendation. And but someone who's having uh, familial history or someone who has found to be a BRCA positive would not go for the risk reducing surgeries. Someone is having strong family history and risk score of more than 20, we calculated the models, online models. For those patients, we suggest an earlier screening 10 years younger to the patient in the family. Someone is diagnosed at 35 years of age in their family and died or survived with the cancer. So we suggest 10 years younger to that point, 10 years younger to the previously diagnosed case, or from the age of 35, we suggest screening of the both breast and as well as ovarian cancer screening test. It should be either 10 years younger to the previous diagnosed one, or at least from the age of 35. General recommendation is we screen all those patients. We give you opportunity screening opportunity for those above 40 years of age.
Right, Dr. Harish. Talking about research advancements or emerging therapies that show promise in improving outcomes for young women diagnosed with breast cancer, or what are some of the therapies that you feel can give some ray of hope for some patients in future? If we talk about immunotherapies, and of course we have newer treatment modalities. So, what are those some of the modalities that you feel are very hopeful when it comes to better health outcomes in future?
Yeah, so in the last 1 decade, in all three subgroups, hormone positive, HER2 positive, and triple negative breast cancer, there are so many of advances in terms of targeted therapy. Uh, Targeted therapy in the sense of like HER2 therapy, anti-HER2 therapy. Initially, used to have only trastuzumab. After that, we got pertuzumab, we got HER2, and we have got oral molecule like lapatinib. And in hormone positive cases, we have palbociclib. These are CDK4/6 inhibitors. Initial, the survival of a metastatic breast cancer average survival is to be 2 years. After advent of like these agents, the survival median survival reached up to 5 years. In a metastatic breast cancer patients, hormone positive, the median survival is reached up to 5 to 6 years, and in those cases, HER2 positive disease with available agents like anti-HER2 therapy along with chemotherapy, pertuzumab, trastuzumab, the survival reached up to 4 to 5 years compared to the 2 years in the past. And in triple negative breast cancer, also the survival increased from 1 year to 2.5 years with all available agents on earth, like with immunotherapy. So, role of immunotherapy and role of PARP inhibitors is more of in triple negative breast cancer, and Herceptin and pertuzumab is a more of in HER2 breast cancer. CDK4/6 inhibitors and PIK3CA inhibitors is more in hormone positive breast cancer. So all the subgroups have their advances in terms of the availability of these new agents, and the survival is doubled and with lesser side effects and in place of chemotherapy.
Dr. Harish, we are almost towards the end of the discussion. But before we part ways, what would be your message? One, to breast cancer, patients diagnosed with breast cancer, what would be your message to them? And of course, to women in general, to be breast aware, to keep, a conscious decision to go for screenings. And, what would be your message to these two groups?
Yeah, so only one thing I know, just which I suggest for all young and older men, like screening. Only thing which can save us from the breast cancer mortality. Screening is shown to be reduce the mortality by 60%. So, and it detects most of the lesions in our stage 1, 2 stages, which are 90% of the times curable. Thus, they live up to more than 15 years. So, screening will always help everyone. And testing for BRCA, especially someone is having in their families, someone known to have developed a breast cancer, ovarian cancer, always they should have a counseling and one-on discussion with the doctor and go for the BRCA testing. So if we have to educate all women in our family, in relatives, to go for the annual screening of the both breast once in a year at least, and second thing to go for the pap smear for cervical cancer, and to vaccinate our young children, young girls less than like 14 years, 9 to 14 years age group, or at least up to we can extend up to unmarried women. We have to vaccinate to prevent against the breast cancer. And apart from that, so mammography is not available everywhere, of course. And those who are in villages, simple self breast examination they can do on their own just to palpate the breast whenever they are going to taking bath. Just to apply with flat hands on the breast just to feel for any abnormal lump which is increasing recently, and anything kind of redness or painless, especially there are painless lumps and red color discharge, bloody discharge from the nipples, and nipple distortion when they have abnormal findings, discoloration of the nipple, and any kind of bloody color, bloody discharge, any abnormal lumps in the breast, immediately they should consult the doctor. Annual examination, if not possible, at least self examination and monthly ones, and the clinical examination by their family doctor or gynecologist once in 3 to 6 months is always advised.
Harish, that was an insightful discussion. Thanks for taking out time from your busy schedule and joining us today. And I'm sure our audience will take a lot of relevant information on how breast cancer can pose unique considerations to young women in the country, and it will help them to further disseminate the information regarding proper detection, early screening, and how treatment modalities can help them get rid of the disease. Thanks for being with us, and thanks to our audience. That's all for today. Thank you. We'll see you in another session very soon. Meanwhile, take care of yourself and keep on following our social media pages. Thank you for being there, Dr. Harish.
Thank you so much. Thank you so much, and take care. Yeah.